I want to talk for a few minutes about musculoskeletal multi-detector CT. And let me get rid of this thing. All right, so I'll talk about a little bit about thinking about the section thickness, the slice thickness that you might need for different MSK applications. Talk about data acquisition, reformation planes, and a little bit about dealing with metal. So sort of historically, when I was in your shoes, we finally had what we consider to be a single detector spiral CT instead of just step and shoot CT. And in that era, you didn't have quite the throughput that you'd have. You only had one detector and one source, and so you'd have to be very thoughtful about how you acquired the data. With multi-detector CT, we have multiple rows. Now, 128 rows, 256 rows, so you're getting many thousands, thousands of scans per second or hundreds of scans per second, so you can use thinner sections and cover more territory. But by way of concept, what I've often thought was useful to think about is you look at the skeleton here, like something like shoulder girdle, something around 3 millimeter sections would be adequate to answer most questions. Around the elbow, something around 2 millimeters thick, wrist and hand, 1 millimeter, possibly 0.5. And the same thing for lower extremity. So around the hip or pelvis, 3 millimeter thick sections should be okay. Knee like 2, foot and ankle like 1. So sort of this 3-2-1 rule. Now, it turns out with multi-detector CT, you can basically set the fundamental detector with whatever the thickness is. So it's often like 0.5 millimeters. And so you can get 0.5 millimeters of everything you want. But then still you can reconstruct images of whatever slice thickness you want. So often what we end up doing here is we end up with the thinnest sections, and then we'll composite a few of those sections together to get something like a 2 millimeter thick slice, or a potentially 3 millimeters, but we're rarely going above 2 millimeters these days, it seems like. So the key points being that, thicker sections for larger body parts. There's more attenuation in those areas like the shoulder and the hip, so the thicker sections have better signal to noise for a given dose. You're closer to radiation sensitive areas around like the chest or breast tissue. So if you can get by with sort of thicker sections, that's better and usually answers the questions adequately. Now, in terms of reconstructing images, typically what we do now is you get like a 0.5 millimeter thick slice and you just reconstruct those at 0.5 millimeter intervals. Back in the day when we did like you get only 3 millimeter thick slices out, it actually was an advantage to do overlapping slices. So you do 3 millimeter thick cuts, but reconstruct them every 1.5 millimeters. And so each slice would overlap the next one by 50%. And that helped with sort of smoother reformations in the opposite direction. So it turns out these days, maybe this isn't quite so critical, but if you're only viewing source images like what we think of as transverse or axial images, just reconstruct at the section width. In some situations, it still may be that you want to do overlapping reconstructions, but not really that critical these days. For MSK, the body parts can move around, so you can do scout in both projections. So a frontal scout here looking at the shoulder, and then it's often a good idea to do a lateral scout to make sure this smaller field of view is centered up on the area of interest. Sometimes if they only do a frontal scout, the technologists will think they're going to capture that, but in fact it's off on the lateral view, and they're not reconstructing the right area of the data. Positioning. So a good thing about limbs is they can be put into different positions, and I'll show a couple examples of that compared with like the body where you're sort of stuck, just laying supine. But for things like shoulder, you can scan this left shoulder, you can move the other shoulder out of the way, or you could kind of hike up this shoulder so that it's getting less attenuation from the opposite shoulder and things like that. Here's an example where a long time ago we had this patient who couldn't extend his elbow all the way, and so we scanned him both with the arm above the head like this, and then with his elbow flexed, and these 3D images you could see that he had an osteophyte off of the olecranon process here that was impinging on the humerus. in the extended position. Then when he's flexed, you can see that there. And this type of thing can be helpful for generating data that a surgeon could use for surgical planning. So also historically, it used to be that, you know, if you're trying to detect something subtle, you're better off to use the sort of primary scan plane to try to find that subtle thing. So for example, we usually think of the primary scan plane as the axial plane, right? So you'd be looking for a fracture on those images that were acquired in the axial plane, because the ones that you would reconstruct from that, the reformations, like in sagittal or coronal, you'd lose some resolution. And so you wouldn't be able to necessarily detect things as well with the reformations. Again, now you can almost think of the CT as like 3D volumetric, so you can detect things pretty well even on reformatted images and characterize them as well. But an example would be something like this, where if you wanted to, in the past, we could take the wrist and put the person in the CT scanner like this, and so the gantry is going across, and you just actually scan long axis across the scaphoid here, getting an image like this. So there's the scaphoid, and so that's sort of the primary scan plane in this orientation, and see things like the scaphoid fracture here, or this fracture of the trapezium adjacent to it. Nowadays, you know, we'd probably just scan transversely through the body part and then reformat in different planes as needed, because the slices are so thin. In the foot, we still do sometimes orient it so that the patient's foot is like flat on the gantry. So instead of like laying on your back with your toes up, your feet are flat on the table. And then the scanner is oriented like this, and you can do a perpendicular scan to things like the navicular to be able to detect subtle things like this lucency, which is a healing stress fracture. A characterization example where here's a patient who was a football player, known fracture of the second metacarpal base. You can see the fractures here, and on a sagittal reformation, these fracture fragments. So this type of 0.625 section acquisition plane and then 1 millimeter thick reformation does a really good job of characterizing these fracture fragments. And you know, that creates good data to be able to make 3D reconstructions like this one, where see the second metacarpal, here's a fracture fragment at the base. And one thing that this showed kind of nicely was that this tendon's actually going and still inserting on that fracture fragment of one of the fragments. So that was relevant when they went to pin this back together. So you have slice thickness, you have orientations you can choose, and then you have reconstruction kernels that you can choose to determine sort of how high frequency of data is reconstructed on the images. So we have mainly two vendor platforms here at Stanford. We have GE scanners and we have Siemens scanners. And in the GE world, you have reconstruction kernels that are called like soft tissue, something like abdominal imaging. You have one that's called bone, and you have one like lung is the same as bone, the high frequency lung kernel. So that's sort of straightforward. Soft tissue or bone are the main two, I think. In the Siemens world, they don't use words like that. They use numbers, and I'll show some examples of that, because in the Siemens, it might say something like I26S or B33, you know, U, or it's like very confusing. It just turns out though that in the Siemens lingo, lower numbers are kind of a softer reconstruction kernel, and the higher numbers like a 70, 90 are very high frequency. So you're going to see higher frequency ones done for like bone, and softer, lower numbers for soft tissues. But generally, we want good high-frequency information on our scan, so we'll reconstruct the CT images in MSK with source image with the high-frequency or bone-type kernels. That's good for multiplanar reformations as well. And then we'll also do reconstruction with standard kernels. So you lose standard or soft tissue kernel, you lose some bone detail, but you get less noisy images. And so that decrease in noise is actually really helpful when you want to do good 3D rendering. So that's why if you look at like one of these Bellino pelvic CTs, it's got a few different data sets. And there's one that's like 1 millimeter thick, but with a soft tissue reconstruction. the main use of that is actually for the 3D reconstruction. It's not necessarily to be viewing it. So it's a combination of needs. Also, if you have metal in place, the standard or soft tissue kernels can give you less metal artifact. So I don't have a lot of information about these different dose reduction techniques for MSK, like ACER or adaptive statistical iterative reconstruction, the things that we're using on abdominal CT to try to reduce dose. In general, many of those techniques tend to cause some kind of blurring in the images that disadvantages looking at bone. So we won't primarily use those in MSK CT. So here's an example on the shoulder where we're doing a preoperative planning scan in a patient with DJD, degenerative and old trauma to the shoulder, a bunch of ossicles here. Here's a 1.5 millimeters thick section done with a B60 kernel, so that's like a bone kernel on the Siemens system. We do the same reconstruction, 1.5 millimeters thick, but with the B30 for soft tissue kernel. And so in this case, the soft tissue kernel is good to look at things like the muscle bulk and rotator cuff. You can't really diagnose a cuff tear, but that's the reason that we'll do two different reconstructions on this data set, even though we're not planning to do 3D per se. Same thing's true in the pelvis. So here's a pelvis, 2.5 millimeter thick sections reconstructed, bone algorithm or bone reconstruction kernel, showing all these fractures. Can you see like higher frequency data, a little bit more noise compared with this? And these are the 1 millimeter thick sections, soft tissue kernel, so that's for 3D reconstruction. The 3Ds we do routinely for our trauma patients, so these are 3D volume renderings, and they kind of simulate the views that the orthopedic trauma surgeons like for their surgical planning, frontal, inlet, outlet. And actually, an AP view is going to be different than a PA view if you're doing 3D volume rendering because of directionality. Actually, this is incorrect. This should be left posterior oblique and right posterior oblique for these so-called Judet views that they use to look at the acetabular columns. And then the lab can do reconstructions where we remove the sacrum and just look at like the normal innominate bone on the patient's right side or the fractured innominate bone on the patient's left side here. Some of the scans we do virtual radiographic views to kind of simulate the Judet views that we do with radiography, and these are quite good. The detail's not quite as much, but they give you some information about fracture, orientation, and displacements, and so on. And in principle, should be able to save the patient extra radiation dose and another trip to the department to do a bunch of different x-rays. I mentioned that the bone reconstruction kernel, the noisier ones, make 3D a little bit more difficult. So here's one of the hand done with the bone kernel. Here's with soft tissue or standard kernel. And you can see when you reduce the noise, you get a much better delineation of the tendons here in relation to the bones. What about reformation techniques? So planes. So here's a knee CT scan, right? And the green and the blue are going to be the reformation planes. And, you know, the critical thing is that you want to do reformations according to the anatomy of interest, right? So these two planes will end up creating the all too familiar sagittal and coronal images, which are basically 45 degrees to what you want, right? And if you're reading out with me, I'll say, great, these reformations are like reference to the world or the CT scanner having nothing to do with the actual anatomy of interest. So what you really want to do is, and have help the text to say, okay, well, here's the knee, here's the femoral condyle, patella. So we want like a true sagittal and a true coronal to get the information that we need, right? It gets harder in the complex planes like reformatting the foot and so on, but sometimes it does require our input with the technologist. So same idea for the shoulder. So axial image, glenoid, humeral head. So we're going to do sagittal images that are perpendicular to the joint here, parallel to the glenoid, giving you images that look like this, parallel to the glenoid, or coronal images, same type of plane we do for MRI, which is long axis along the shoulder girdle, giving you glenoid, humeral head, see the supraspinatus muscle going into tendon here. Okay, so same thing. This is that same patient I showed pre-op planning. We'll get oblique coronals and oblique sagittals, both in that bone and in the standard kernel. A couple other examples here. So section thickness. So here's a young patient who had wrist pain, and a CT was done of his carpus, the wrist, and so 0.5 millimeter sections, very sharp kernel, so bone reconstruction kernel, and really good bone detail. Even on this multiplanar reformation, it almost looks like a primary acquisition plane. But we could see that he had a coalition between these two bones, so lunate triquetrum here, a congenital fusion, another fusion over here, or sort of lack of segmentation. And both those things were causing a lot of stress across this scapholunate interval here, because that was the only joint that he had left, really. So that got widened, got some degenerative change there at a very early age. This is sort of a joke slide, but it's like this was a finger CT, and you know, we don't do these very often, but this was one of the Nobel laureates at Stanford, and so we had to you know, pull out all stops, and so we did very thin sections, 0.5 millimeter cut. So here's the axial sections of like 2 adjacent fingers, showing this sort of die punch fracture. But we wanted even more detail, so we overlapped them at so 0.5 millimeter sections at 0.25 millimeter intervals to see this little die punch kind of fracture. You know, this I would say is like, you know, this was a Nobel laureate, and like this was the digit that he used to push the button on the machine that led to the actual Nobel Prize. So it was a very important, very important finger. Of course, the surgeon will use something like this to kind of decide, okay, I have this slightly depressed little fracture of this very important finger. Can I improve on that, right? And that's their gestalt. And I don't know that they could improve on this one, but good data. So here's a pitfall too. So you're doing a scan and you tell the tech, so I need some sagittal and coronal reformations, and the reformations come out and they look terrible. That could happen, right? Does that ever happen to you? Some of the scanners are set up so that they default the slice thickness on a reformation to the same as the pixel size on the source image. So, for example, if you did a field of view, and it's always a 512 matrix for the axial images, a field of view that led to pixels on an axial plane of 0.625 millimeters thick, or sorry, in dimension, then it would say, oh, you like that 0.625, that's how thick I'm going to reconstruct the reformation, because they're square voxels that way. But that's not necessarily the right thing to do, because you end up with noisy images like this one. So here's a sagittal reconstruction of the knee. It's a little noisy. You could say, you know what, I don't want the same pixel thickness. I want something like about a 2 millimeter thick section in sagittal. Really decreases the noise, maybe see the fracture a little bit better, and is kind of a sweet spot somewhere in there. So we do a lot of reformations around 2 millimeters thick. At some point, you probably go too far, so I made this one as 4 millimeters thick just as a trial, and you can see maybe that fracture starts to get a little bit blurrier and it's harder to see. So somewhere, you know, around 2 millimeters might be the optimum thickness for much of what we do. Does that make sense, or does that pitfall kind of make sense? So if you look at, so if you go back to the scanner and say, boy, those reconstructions look terrible, and you can see how they're being put together, and on some of our machines, like on the, you know, maybe even on the new packs, I'm not sure, you could choose your section thickness, and you might want to choose it to be like 2 instead of have it be really, really thin. Here's a patient who was a big patient, and she had crashed her car and came in as a trauma. And so these are 3.75 millimeter thick sections, but she was complaining of left hip pain, okay? So this is a challenging examination to do. Fortunately, our scanners have a high weight capacity these days, so we can scan big patients, but still there's a lot of tissue to get through, so it could be pretty noisy. So the question was, what about this left hip? Well, the images they gave us were these, 1.25 millimeters thick. Here's that left hip. It's like, doesn't look quite right there, right? But it's like, do you want to send somebody to the OR based on this image? No. So in her, we actually made fairly thick reconstruction thickness, 6 millimeters, in order to average out some of the noise. And that convinced us, yeah, there is in fact a fracture that involves that femoral head, and then the surgeons could go in on that more confidently. So you can play with the slice thickness and reconstruction thickness to optimize the images. Now, metal can be a problem with CT. So how much artifact you get depends on how much metal there is, sort of the bulk of the metal. Is it a little tiny screw, or dental hardware, or is it a huge rod or something like that? Depends on what its orientation is in the scanner. And then you can set up the CT scanner to try to minimize the artifact from metal, which we'll talk about in a second. It depends also on the type of metal. So there's some metals that you can think of being slightly softer or more favorable to X-ray, like aluminum. Then you get to titanium, then you get to stainless steel, and cobalt chrome. That's like your car bumper, right? That's like pretty damn hard. And so this is what some of the older hip prostheses are made of, and some of them still have chrome in them. So there's a tremendous amount of artifact that you get off of those cobalt chrome prostheses. So how can you help minimize artifact or get around it? You can scan short axis to the hardware. So, the last thing you want to do is, like, let's say you have somebody with a plate in the forearm or something like this. You don't want to put them in the gantry so that it scans the whole length of that plate. You want to go perpendicular, so you're scanning short pieces of the plate at one time and then reformat images. You can go to higher energy to penetrate through more. You can also go to high voltage as well as high energy, turn up the MA on the scanner, more photons to go through. Thin sections are helpful because then the scatter in the Z direction is less, so you can have better quality reformations if you do thin sections in the acquisition. Changing the kernel can help to decrease the amount of noise. You may do two orientations if you're really trying to answer a question. And then there's a number of techniques that I'm not going to get into that are like metal artifact reduction techniques that are coming around and are pretty good. So here's an old example of a basketball player who had a fifth metatarsal fracture, and he had a screw in place, a solid orthopedic screw, and he felt another crack, when he was playing a game. This was maybe 6-8 weeks after the screw was placed. So the question is, did he refracture? And so in this situation, we scanned him twice, actually with the foot flat on the scanner table. So, and then the beam is going like this. So that's that orientation. Then we did a second scan where we went obliquely to try to just minimize the amount of artifact on two different planes. Then we could reformat and say, yeah, in fact, there was another lucency there that was a refracture in his case. Another metal example, here's a patient who had a hip replacement placed, I think, about 6 months before this scan at an outside facility, and she's complaining of right lower extremity pain. And this is sort of worst case scenario for metal artifact because you have bilateral hip replacements. So in between those, you're going to get complete dropout of photons and a lot of artifact. But outside that, you can do pretty well, and you have to like widen the window. So take a look at this right over here. See that white thing right there sticking back? And then so on a more of a bone window level, you can see that right prosthesis had this screw projecting out beyond the bony margin of the posterior acetabulum. Here's a sagittal going right into a yellow structure right back here. Actually, it's a green structure on this next cartoon, the sciatic nerve. And so even though there's artifact here, you can have a targeted clinical question and actually get quite good CT despite the artifact. That patient went in, a neurosurgeon went in and trimmed off that screw, and it was actually impinging on the common perineal division of her sciatic nerve. Unfortunately, it had been in for so long that she really didn't actually recover much function from the leg drop, the foot drop that she had, like in the recovery room. She's like, "Doc, my foot is this is killing me. What's wrong?" He's like, "Nah, you're going to be fine." We don't know. So to wrap up, a little bit on this, so you can think of that sort of 3-2-1, 2-1, 0.5 thickness concept for reconstructing images. The positioning can be creative. Know a little bit about the kernel effects, and then reformat according to the joint anatomy, not to the world or the scanner. And then the hardware principles: jack up the KVP, jack up the MA, don't go long axis to the hardware, and so on. So that's the first part of that, and I'm happy to answer any questions on this portion. Let's see if we can